So this is non-invasive hemodynamic monitoring assignment for anesthesia 411. My name's Laura Carson, and today I'm going to be talking about non-invasive and invasive monitoring, specifically the pulse contour analysis and thermodilution methods. So to start, I'm going to talk about my non-invasive hemodynamic monitor that I chose, which is pulse contour analysis. This method takes the systolic portion of an arterial waveform, which the arterial waveform can either come from an invasive arterial line or a volume clamp method, but normally from an arterial line. Then taking this analysis of the systolic portion has an algorithm that takes into account your height, your weight, and sex and other demographics, and generates values such as stroke volume, cardiac output, systemic vascular resistance, blood pressure, pulse pressure, but most importantly, cardiac output. For my invasive hemodynamic monitoring technique, I chose thermodilution. This is the most common and gold standard for cardiac output. This measures the cardiac output via a thermal or a time temperature curve, which is given by the measurement of an injectate at the thermistor of the pulmonary artery catheter. So my experiences with these two methods, the pulse contour analysis is unfamiliar to me. I've never seen it clinically used. Thermodilution, on the other hand, I have seen used once as a respiratory therapist, and it was in the cardiovascular ICU on someone with a pulmonary artery catheter. I think the reason that they're both so unfamiliar to me, specifically thermodilution, is because pulmonary artery catheters aren't used quite so much in my facility, as we don't have a lot of cardiac patients, and therefore they don't need these invasive lines. So just the principles and a little bit of how they work. Pulse contour analysis, like I said, it uses the arterial line waveform, specifically the systolic portion. And it kind of evaluates the under the curve to determine what the cardiac output would be at each point of the cardiac cycle on the monitor, and takes into account the demographics of the patient to calculate cardiac output. For the thermodilution method, there is an injectate that is usually, or it's always lower than the temperature of the blood. It's injected into the proximal port of the pulmonary artery catheter, which then allows the bolus of the injectate to pass through the right atrium, the right ventricle, and then into the pulmonary artery, which is where there is thermistor beads that record the temperature. So this is then plotted on a time temperature curve. And this plot is of the differences of blood temperature from start to finish. So cardiac output is inversely proportional to the area under the curve. The top or the peak of the curve is the lowest temperature, so the greatest difference between the two. And to get the final cardiac output value from thermodilution, it takes an average of 3 measurements. So where to use? I found this question a little bit difficult just because I don't see them clinically used. However, I would say that anything cardiac would be a useful place to have both of these methods used. So intraoperatively in any cardiac surgery, or postoperatively in the cardiac intensive care unit. For cardiac patients, a lot of the treatments and therapies can be directed based on these measurements of cardiac output. So therefore, I think it would be beneficial to have in these two locations for sure, if not in other locations in the hospital, if feasible, such as the regular intensive care unit or the emergency department. So now to just do some advantages and disadvantages. For the pulse contour analysis, some big advantages are that there's no risk from the procedure itself. And because it uses an algorithm, there's really minimal source for human error. The only thing with the infection risk is that it does require usually an arterial line, so there is an infection risk from that, but that would probably already be in place. If this were someone we were concerned about getting their cardiac output, they would already have invasive blood pressure measurement going on. For thermodilution, the advantages are that you don't have to take a blood sample to get the cardiac output value. It's very quick for the clinician to perform. It doesn't take a long time, and the results are available to the clinician immediately. Some disadvantages for the pulse contour analysis, it, like I said, requires an invasive arterial catheter or a less reliable method, such as a volume clamp, to generate the waveform. It's inaccurate in low cardiac output or systemic vascular resistance changes, also with intra-aortic balloon pumps. As it is dependent on the arterial waveform, it is really affected by any over-under dampening of that waveform. So it really needs to have a very accurate arterial waveform to generate an accurate cardiac output value. It also uses mostly calculations to get the value. It's not directly measured, so that's a disadvantage as well. For thermodilution, the disadvantages are it's less accurate in those with lower cardiac outputs. You can have injectate or thermistor issues. You have to be careful with rewarming after bypass or rapid fluid administration because that can make your results less accurate. There is a little bit of a delay, the time that it takes for the injectate to travel from the right atrium all the way to the pulmonary artery and get read. So it's not, beat to beat quite like an arterial line. It's also sensitive to respiratory variations and arrhythmias. So with the respiratory variation, to avoid this affecting your results, you should either take it. You should take it in every in the same portion of the respiratory cycle in every measurement to ensure that all your values are being matched equally. For accuracy, the pulse contour analysis accuracy really depends on the accuracy of the arterial waveform that it's reading. Two studies that I looked up, a study by Brock et al. In 2015 showed poor ability to estimate cardiac output when it was compared to thermodilution. A percentage error was calculated by Metzinger et al. 2014, and it was around less than 20%, so not great. The thermodilution accuracy, according to Darvok 2002, had a reproducibility of 5% when triple measurements were taken. So overall, I think the thermodilution has better accuracy and is less affected. The accuracy is less affected by less things than the pulse contour analysis. For cost, I couldn't really find an exact cost. However, for the thermodilution, it requires the special swan gaze catheter that has a thermistor tip in it. And of course, with the insertion of a pulmonary artery catheter, you're going to have sterile drapes, needles, the doctors and nurses, and medications. For pulse contour analysis, it requires an arterial line insertion at some point. But overall would require less nursing services after initial setup because it's all computerized with the algorithm, whereas the thermodilution requires the clinician to do the injectate. For future monitoring, There needs to continue to be work on non-invasive monitoring methods that compare in accuracy to the gold standard, as well as I don't think these methods are being used routinely, and I think if better methods are found, we're able to use them more routinely on people and maybe direct our therapies a little bit better. And that's everything. Thank you very much.